Hello and good day. I am Christine Baini and I will be presenting my clinical case study MR11, which is MRI liver. So first I would like to introduce my case study just briefly. So the patient is a 45-year-old Caucasian male, has history of renal failure, which is kidney failure stage 3. He has no history of abdominal surgeries, and previous radiological examinations are the ultrasound for right upper quadrant and abdominal CT with no contrast. So for the abdominal CT with no contrast, it has been found that this patient has a large hepatic mass and multiple enlarged pelvic, inguinal and retroperitoneal lymph nodes, hepatic mass encompassing the nearly entire right lobe of liver, and the mass is also described as hypoattenuating with centrally located necrotic areas and peripheral areas of hyperattenuation. So the recommended procedure for this patient is MRI liver in order to further evaluate the hepatic mass. So why is MRI preferred in this case? It is because basically MRI is excellent in soft tissue contrast and anatomical detail. And when we compare to CT, MRI also has superior contrast resolution, and it has the ability to provide both morphologic and physiologic information. So from a journal by Wang et al., it has been found that MRI has higher sensitivity and specificity, which is 78.82% for sensitivity and 78.46% for specificity compared to CT scan, which is lower, 62.35% and 73.85% for the diagnosis of hepatocellular carcinoma. So there is significant difference in sensitivity, accuracy and negative predictive value between MRI and CT screening. So in this article, it was concluded that when CT screening is not sufficient to accurately determine liver tumor lesions, MRI can provide a more precise imaging basis. So since this patient has renal failure, so it is not recommended to administer contrast for this patient because it will harm the patient. So we will opt for non-contrast MRI of the liver. So how well is the performance of non-contrast MRI for the liver? So from this journal by Han et al., MRI performance in detection of liver lesion and function evaluation has improved because there are improvements such as these features: multi-channel surface receiver coils, parallel imaging techniques, and we also have fat suppression, we have the diffusion-weighted imaging, and the adoption of the hepatocyte-specific contrast agents and multiple arterial phases. All these features are helpful in order to characterize the liver lesions in MRI, even though we have no contrast. And compared to an enhanced CT or MRI, a non-contrast MRI is easy to perform. It requires less acquisition time because if we use contrast, we will need to have the post-gadolinium sequences. So without the contrast, then we will not have to perform post-gad sequences. There is no need for contrast media, so there is no risk of side effects to the patient, and relatively also less expensive. And lastly, MRI also has the advantage of no radiation hazard. So from other studies, for example from Kim et al., it has been found that there is no significant difference in sensitivity between non-contrast MRI and standard MRI. And if we use pooled data for sensitivity, MRI that has contrast, which is the standard MRI, will still have better sensitivity, but it is only a difference of 3% between the contrast and non-contrast MRI. This is possibly due to recent improvement in DWI and T2 weighted imaging quality, as I mentioned earlier from the study by Han et al. Next, there is also another study done by Huang et al. In 2018, which is quite recent. It is comparing the diagnostic accuracy of non-contrast MRI with whole MRI with gadocetic acid for detecting liver metastasis from colorectal cancer. So this study actually compared the diagnostic accuracy, and it showed similar findings with Kim et al., which is this study, which is there is also no statistically significant difference in sensitivity. And this journal also recommended active implementation of non-contrast MRI when CT findings are inconclusive or suspicious of liver metastasis. So this is how well the MRI non-contrast can be performed. So next, for the patient preparation, because this patient does not require contrast, so the patient preparation is less strict. So first, when the patient comes to the department for the MRI, first we have to correctly identify the patient. Then we have the patient to go to the toilet before the study, and then we will explain the procedure to the patient, and we ask the patient to remove all clothes containing metal, because this is we will be examining the liver region. So if the shirt has zips or metal buttons, the patient will have to change into hospital gown, and if the patient is wearing jeans, they will have to remove the jeans and wear hospital gowns also. And ask the patient to remove anything containing metal, for example, if there is any earrings or jewelries. Then we will also offer the patient earplugs or ear protectors, because it will be noisy inside the MRI, and we will also inform the patient of this. Lastly, before we start the procedure, we have to ensure that patient has truly understood the procedure, including how long does it take, and we will also give the emergency button to the patient. So if there is any emergencies, for example, if the patient cannot breathe or the patient is restless, they can press the emergency button. Next is for patient positioning. The patient will be positioned supine, head first. Pillow is given under the patient's head to support the patient, and the patient is positioned over the spine coil, and the body coil is placed over the upper abdomen, which is the nipple line down to the iliac crest at this area. So the body coil is securely tightened using straps to prevent any respiratory movement. Cushions are placed under the patient's knee for comfort, and the centering for this MRI is at the xiphoid process of the sternum. So the MRI sequences is the axial T1 weighted imaging. For T1 images, the structures that will be low intensity or dark is iron, water, air, bone, collagen, and most tumors. So the structures that will appear as bright is fat, melanin, blood, protein, paramagnetic substances, and also gadolinium contrast. For normal liver, we will see uniform T1 isotense to the paraspinal muscles and slightly hyperintense to the spleen. But if the liver is abnormal, the liver masses are commonly both benign and malignant. They will usually appear as low signal intensity. Actually, T1 is not useful to distinguish a benign from a malignant lesion. And for T1 fat saturated, it will be used to assess lesions with intrinsic hyperintense T1 signal, for example, hemorrhage, melanin, and proteinaceous debris. So actually, T1 is more to anatomical information. Whereas for the next sequence, which is T1 in phase and out of phase, this is a useful sequence for MRI liver because it assesses fat-containing liver lesions and hepatic steatosis, which is to differentiate the lesions between which lesion is composed of fat and which lesions are not composed of fat. So for lesions that are composed of fat, they will appear as a signal drop in out of phase images, and if there is signal drop in phase images, this is usually seen in iron deposition. Next is axial and coronal T2 imaging. For T2, the structures that appear as dark is air, bone, and hemosiderin, whereas structures that will appear as bright is water, edema, fat, blood, and most tumors. So the difference between T1 and T2 is, if in T2 the fat and blood and most tumors will appear as bright, whereas in T1 it will appear dark. Masses such as hepatic cysts, biliary hematomas, abscess, and hemangiomas will also appear bright in T2. And solid hepatic mass are typically hyper-intense, but not as bright as cysts. T2 is excellent for detection of liver lesions due to high contrast, and is also useful in characterizing benign lesions, cysts and hemangiomas. There is also T2 fat suppression, which is this sequence will increase the contrast between a lesion and the liver, so this will better differentiate the liver lesions in MRI liver. Next is the diffusion weighted imaging. Diffusion weighted imaging actually provides information about the Brownian motion of water molecules in a voxel. So when we use DWI, water molecules that move freely will be termed as unrestricted in their diffusion, and this will result in low signal intensity or dark in the image. And water molecules that do not move freely will be termed as restricted diffusion, which demonstrates high signal intensity, which is bright. Usually tumors are categorized in restricted diffusion, so they will appear bright in DWI. Then DWI also has this ADC map, which is the apparent diffusion coefficient, which is used to quantify the degree of diffusion restriction. Cystic masses and necrosis will have high ADC values, while solid mass and tumors will have low ADC values. So this is an example of image of DWI and ADC. So this shows a restricted diffusion area here, which we can see it is bright, but in ADC map it is dark. So it's actually opposite. If there is restricted diffusion, in DWI we will see high signal intensity, but in ADC map you will see low signal intensity. And this picture is actually indicates residual or recurrent hepatocellular carcinoma. And this picture is taken from the journal by Wu et al. So that is all from me, and these are my references. Thank you.